Hi, I'm Dr. Douglas Galasko, a neurologist in the Department of Neurosciences and Associate Director of the Shiley-Marcos Alzheimer's Disease Research Center at UC San Diego. I'm going to talk about implementing anti-amyloid therapy for Alzheimer's disease and going on to gain real-world evidence. Alzheimer's disease is now viewed as a biological construct. We know from many pathological studies that Alzheimer's consists of lesions that build up in the brain with amyloid deposits forming plaques and tau deposits forming tangles. The presence of both of these is necessary for Alzheimer's disease to be present pathologically. And in addition to both of these, we also require neurodegeneration. If amyloid and or tau pathology are present on their own, we think about this as Alzheimer's pathological change. We also know that many patients, especially in the age range of 70 and older, have additional brain pathologies that may contribute to cognitive decline. And these would be non-Alzheimer's pathological changes. Some of the most common of these involve aggregation of the protein alpha-synuclein, which we see in Parkinson's and in Lewy body dementia, a protein called TDP43, which aggregates in frontotemporal dementia, but also in a condition called late, which is a disorder that can cause cognitive decline in usually very elderly people in their 80s or beyond. And then vascular changes. Amyloid builds up in blood vessels and can cause damage. Also, as a result of factors like high blood pressure and diabetes, there can be small vessel changes in the brain with resultant impact on brain performance and sometimes resulting in stroke. All of these can build up asymptomatically, or they can be associated with cognitive impairment. So we can think about some of these pathologies existing in people who have normal cognition, subtle cognitive decline, mild cognitive impairment, or all the way to dementia, with neurodegeneration progressing along all of these different stages, which really are a continuum. So if we think about staging Alzheimer's, the staging system proposed is called ATN, amyloid, tau, and neurodegeneration. And while I've shown you ways to assess these pathologically, we now have a range of biomarkers and methods to assess these clinically. The first to build up is amyloid, which is shown in this scheme, starting in people who are cognitively normal. Then tau builds up and spreads from early brain regions in the medial temporal lobe to more widespread pathology. And again, this can start in people who are cognitively normal and progressively worsen in concert with a cognitive decline. And then neurodegeneration, one marker for which is brain atrophy or shrinkage, which we can see on MRI. And then tests of memory and clinical function. And we can try to stage these clinically. Three broad stages are cognitively normal, MCI, and dementia. And if we are now going to approach amyloid immunotherapy for Alzheimer's disease, the course and the time point at which amyloid monoclonal antibodies were studied was called early Alzheimer's disease, which includes MCI, or mild cognitive impairment, and mild dementia. So this is the setting for clinical trials and for the approved use of anti-amyloid antibodies. We have an array of biomarkers that can be used to try to detect these different pathologies. And this is highly relevant to clinical practice and how we implement amyloid immunotherapy. For diagnosing A or amyloid plaques in the brain, we can use amyloid PET, or we can do a lumbar puncture to measure CSF levels of amyloid-related proteins, A-beta 42, A-beta 40, or phospho-tau, or we can measure these in the blood in plasma. To measure tau burden in the brain, we need to resort to tau PET. There's one test for a form of phospho-tau that was recently developed that may track the tau burden to some extent. And then neurodegeneration involves many different processes. It's illustrated here by a normal brain or the brain of someone with normal cognition on the right, and the brain of someone with Alzheimer's disease on the left. As you can see on the left, there is shrinkage of the brain with shrinkage of the gyri or folds and enlargement of the sulci or grooves. So to diagnose N, we can try and look for markers of anatomy. We can do a brain MRI to look at atrophy or pathways that connect different brain regions. We can do a PET scan to demonstrate how well the brain uses glucose. Areas undergoing neurodegeneration use glucose much less avidly than the normal brain does. And then there are biochemical tests. We can measure a number of proteins that are released during neurodegeneration, either in the spinal fluid or in plasma. And these will include neurofilament light and a particular different forms of tau. One called brain-derived tau or BD tau seems to show a lot of promise. So lots of biomarkers that we will then use to try and make a positive or a biological diagnosis of Alzheimer's disease. So before considering treatment with an anti-amyloid antibody, we need to make a positive diagnosis of the presence of brain amyloid. In order to do this, there are a number of different biomarkers, as I have indicated, and so there is a choice of what to do. This lists a scheme of some of the options. And again, we can try and detect plaques. I haven't approached tangles in this particular schema. There are means such as tau PET, but we're going to focus on amyloid because the therapy of anti-amyloid antibodies targets amyloid. So we can do an amyloid PET scan in which a tracer is given intravenously. It circulates through the body and gets into the brain. And if there are amyloid deposits in the brain, then by taking a PET scan, the radioactive tracer will emit radiation, and this is detected, and so the brain lights up as indicating positivity for amyloid. One can also do a CSF test through doing a lumbar puncture or a blood test, and here we measure proteins. The proteins are called A-beta 42 or amyloid beta 42. We can measure it on its own or as a ratio with a similar protein called A-beta 40. We can measure p-tau 181 in CSF or p-tau, this should be 217 in plasma. And these are indirect indicators of the presence of amyloid plaques in the brain, but they are highly accurate. Amyloid PET scans become positive quite a few years before the development of symptoms due to Alzheimer's disease. And this is an illustration of amyloid PET scans in someone who might be normal and amyloid negative, normal cognition, amyloid positive, MCI not due to Alzheimer's disease, in which case this person is amyloid negative, MCI due to Alzheimer's with MCI and some amyloid positivity, MCI and a lot of amyloid positivity, dementia due to Alzheimer's with amyloid positivity. So we have ways of trying to grade positivity. In clinical practice, scans are simply read as being positive or negative. In research settings, we can actually try to quantify the burden of amyloid positivity by something called an SUVR, a standard uptake volume ratio. So this illustrates the difference and the overlap between measuring CSF A-beta 42 shown in panel A, or 42 as a ratio over 40, compared to measuring amyloid PET. The tracer here was called flutometamol. And the idea is that if amyloid is deposited in the brain, CSF A-beta 42 or A-beta 42 over 40 is decreased, as shown in the bottom right shaded panel. That same panel indicates amyloid PET positivity, where there's an increase in the buildup of amyloid PET. If amyloid PET is negative, in other words, not detecting amyloid, then CSF A beta 42 is normal. So the amyloid protein traffics into the CSF and does not deposit in the brain. We now are able to measure A beta 42 and a number of other CSF biomarkers using FDA-approved assays. There are 2 platforms available, and these are fully automated and have an accurate and sensitive readout. AUC is one way of assessing the accuracy of a test. This is overall accuracy in a group of people who are positive and negative for a gold standard test. And accuracy close to 1 is desired. Here, for the ELIXIS test, the ratio of p-tau over A beta 1 to 42 achieved an AUC of 0.944, which is pretty close to 1. T-tau over A beta 42 came close. A beta 42, p-tau, t-tau on its own were not quite as good as some of the ratios. So in practice, we tend to use ratios, either p-tau over A beta 1 to 42 or 42 over 40 as a CSF diagnostic. In terms of blood, it took many years to begin to develop blood tests because the levels of the same markers that we can detect in CSF are considerably lower in the blood. For amyloid beta 42, the most accurate test currently was developed by a company called C2N, and this measures the ratio of A beta 42 over 40. The top panel shows how this performs in people who were negative by an amyloid PET scan versus positive, where there are clear differences, but also a fair amount of overlap. If age and ApoE4 genotype are also considered, ApoE4, which I will talk about in a moment, is the strongest risk factor for developing Alzheimer's in later life. Putting age, 42 over 40, and ApoE into a formula came up with better separation, and this test is available and was called Precivityy. It turns out that measuring p-tau 217 in plasma is even more accurate. There are a number of different companies and tests that have been developed with different methods of measuring p-tau, and this was a head-to-head study in which p-tau 217 measured 3 different ways, was compared to different forms of p-tau, measured again by different assays in a group of people who were either amyloid positive or negative, measured by amyloid PET. And this showed that the best of all of the p-tau 217 assays had an AUC that was considerably greater than 0.9, so it was about 0.95. The second best p-tau 217 was just marginally better than 0.9. So these are highly promising tests to be able to make a diagnosis of Alzheimer's by drawing blood. In terms of comparing some of the blood tests, it turns out that plasma A beta 42 over 40, while it does show differences, is difficult to measure very accurately because the difference between PET positive and negative is only about 10%. p-tau 217 is more sensitive and specific than p-tau 181. And even though this test measures a fragment of the tau protein that builds up in tangles, these 2 tests correlate best with amyloid PET and not so well with tau PET. At present, there are a number of different tests available to measure p-tau 217. One of them uses mass spectrometry developed by C2N Diagnostics. A number of others that are quite sensitive use immunoassays, and here are some of the vendors. And a different mass spec test for a part of tau that originates from the microtubule binding region showed a fairly good correlation with tau PET and may help us get some sense of tau burden in future. So blood-based biomarkers raise a number of new questions. Which of these tests are the most efficient and affordable? How do we combine these with cognitive screening? We don't want to randomly introduce blood-based biomarkers in the population at large. Who should be tested and where? Should this be done in a primary care setting or a specialty clinic? Can the blood-based biomarker be a screen before a PET test or a CSF test, or maybe can it be used on its own in order to decide about amyloid immunotherapy? How do we disclose the results of plasma biomarker tests in people who have symptoms? And as we eventually study prevention strategies for Alzheimer's in people who lack symptoms, and how do we disclose the risk, for example, being ApoE4 positive, having a positive amyloid biomarker, and so forth, in someone who is asymptomatic or minimally symptomatic? So these questions are receiving a lot of research, but are already essential as we enter the era of amyloid immunotherapy. So how do we discuss and approach amyloid immunotherapy with somebody who has a biologically confirmed diagnosis of Alzheimer's disease? At present, there are two FDA-approved antibodies. One is called lecanemab or Leqembi, and this binds to soluble protofibrils of amyloid. It also clears amyloid from plaques, and there have been positive phase 2 and phase 3 clinical trials. Donanemab, which is marketed as Kisunla, binds to an insoluble form of amyloid. It also clears plaques, and there have been positive phase 2 and phase 3 trials. As I mentioned, both are FDA approved, both are covered by CMS or Medicare. And in the phase 3 trials, both antibodies slowed clinical progression. They did not arrest or reverse clinical progression. Both were associated with an adverse event called amyloid-related imaging abnormality, or ARIA for short. And the presence of ARIA resulted in a boxed warning from the FDA around the package insert for these drugs. So what is ARIA? There are two different variations of ARIA. One is called ARIA-H, short for hemorrhage. And in this image on the right, the red circle indicates a few small black areas that are the leftover residue of iron that is in small areas of hemorrhage. The iron stays visible on MRI, shown in certain specific MRI sequences for a long time. The other kind of ARIA is called ARIA-E, or ARIA encephalitis, or ARIA edema. And here, the ARIA has led to damage to a blood vessel, leakage into the contents, a leakage from the blood vessel to the brain, and the arousal of inflammation with this kind of abnormal white matter picture, sometimes some swelling on MRI. So most episodes of ARIA turn out to be asymptomatic, but we can see them very sensitively on MRI. Symptoms can occur as a result of ARIA. These include headache, nausea, confusion, dizziness, rarely stroke or seizures. So how do we mitigate ARIA as we introduce antibody immunotherapy into practice? The most important thing is patient education and awareness, and then safety monitoring. We perform a baseline MRI before anyone starts immunotherapy. And just as in the clinical trials at UCSD, we are not offering immunotherapy to people who have more than 4 microhemorrhages at baseline. We then monitor by doing safety MRIs at 2, 3, and 6 months. And if symptoms emerge, it turns out ARIA is much more common early in the treatment. Here is a snapshot of the clinical trial results, which we will discuss with patients. Lecanemab or Leqembi has to be given intravenously every 2 weeks, and in the clinical trial, this occurred for 18 months. In this clinical trial of almost 1,800 participants, there was a slowing of clinical progression. The trial uses several different outcome measures, which are different than the tests we use in clinic. The CDR sum of boxes is a global test based on an interview of the patient and an informant. And in the study, there was a decrease by about 27% of the amount of progression on the CDR sum of boxes. Amyloid PET, as shown in the second panel, in people on placebo, amyloid PET did not change. In people who received lecanemab, over 12 months, there was a fair amount of change, and over 18 months, an even greater change. Amyloid PET is measured in a scale called centiloids, and there was an average change of over 50 centiloids. The AD-COMS was a composite test using a number of different cognitive and other measures. It changed with treatment and on placebo with a benefit of 24%. And the ADCS-ADL-MCI is an interview in which people are asked about how they perform complex daily activities, and the benefit of treatment was 37% slowing. How common was ARIA? ARIA-E occurred in 12.6 people on lecanemab, and in 2.8%, this was symptomatic. ARIA-H, 8.9% of lecanemab treated people versus 7.8% of placebo. And if we look at people who were carriers of the ApoE4 gene, people who lacked the ApoE4 gene had about a 5% ARIA rate. People who had one copy had an 11% rate. People who had two copies had a 32% rate. So we need to be more aware and more cautious in people who had two copies. Having said that, symptomatic ARIA was rarely irreversible and only sometimes led to the need to stop treatment. Sometimes after ARIA and symptoms, treatment could be resumed. This is a summary of how donanemab, the other approved antibody, performed in clinical trials. This is a phase 3 trial over 18 months, and donanemab needs to be given intravenously every 4 weeks. Unlike Leqembi, it is given 4 weekly, not 2 weekly. And again, the trial went on for up to 76 weeks. The study population was MCI, or mild Alzheimer's disease. And there was clearing of amyloid in about 80% of people by 76 weeks of treatment. The tau burden was measured by PET scanning at the beginning of the study, and it turned out people who had a lower tau burden had stronger clinical benefits. ARIA rates were slightly higher for donanemab than lecanemab. There was overall a 1.6% rate of serious ARIA. The figures illustrate the differences between placebo and treatment. So there was slowing on a scale called the ADRC, which is a mixture of cognitive testing and interview about performance of complex activities, and 35% in people with low or medium tau, 22% benefit in the entire trial population, 35% slowing of the CDR sum of boxes in low or medium tau, 29% slowing overall. So these are approximate numbers that we will mention and discuss with patients as we think about having a discussion about amyloid immunotherapy. The Alzheimer's Association reviewed these data, did a number of additional analyses, and mentioned that, in their opinion, aducanumab, which is an earlier study, and lecanemab or Leqembi, and donanemab all give people more time at or near their full abilities to participate in daily life, remain independent, and make future healthcare decisions. They do not reverse Alzheimer's disease, however. This shows what happens beyond the 18-month period in the clinical trials, in the clinical trial of lecanemab or Leqembi. So in the study, people continued to be treated beyond 18 months, and on the left, their amyloid PET burden remained low. People who were in the placebo group in the initial study were then offered Leqembi treatment in OLE, or open label extension, and over the next 12 months, on average, their amyloid PET burden decreased. One can try to indirectly monitor this by doing a blood test and monitoring the ratio of plasma 42/40. As I mentioned earlier, plasma 42/40 is decreased in Alzheimer's, but as you remove plaques, it tends to normalize and get back to the normal range, as is shown in green in people who were treated with Leqembi, and in people who were on placebo and then later given Leqembi, there was also a later increase in 42/40. How about plasma p-tau 181, again, another indirect amyloid marker, and plasma p-tau 217, once again, if one looks at the green lines, this shows that in Alzheimer's disease, both of these forms of p-tau are increased in plasma. With treatment and removal of amyloid, they tend to decrease, and this persists over time. In the open label extension, people who did not receive treatment but received placebo show a later decrease in p-tau 181 or p-tau 217. So perhaps these could be used to monitor ongoing treatment in future. This shows a couple of other markers. I mentioned that there are some new forms of tau that can be measured. One of them is called microtubule binding region form of tau, and here Leqembi showed a decrease in the overall level of MTBR tau, suggesting that there is a decrease in the buildup of tau in the brain as a result of treatment. On the right, the results of tau PET are shown. Again, there tends to be a decrease in the accumulation of tau with the removal of amyloid. And finally, there is a rebound in plasma biomarker levels after treatment was stopped. And there's a sense from some of these data that ongoing treatment with Leqembi beyond 18 months may be needed to maintain improvement of plasma biomarkers. Since this was not studied in a rigorous way against placebo, we don't know if this is essential for clinical benefit or how much this will give us clinical benefit over a long term. And this is one reason to introduce further studies in registries, which I will talk about in a moment. So what is the impact of anti-amyloid therapy on practice? Now that these therapies are available, we need to be able to detect and diagnose MCI and mild dementia. We should then determine if Alzheimer's disease is causing the cognitive decline versus something else, and therefore we need to employ confirmatory biomarker tests. We should explain the risks and benefits of anti-amyloid immunotherapy to patients, refer appropriate patients for consideration of therapy, and where we are implementing therapy, we need to monitor for safety after we start treatment. What is the role of primary MDs in this workflow? At the moment, we think that primary MDs should have some knowledge and awareness that there are a variety of new diagnostic tests available to help us to make a positive diagnosis of Alzheimer's disease. They should know who qualifies for potential treatment with Leqembi or Kisunla. This is people who have mild cognitive impairment or mild dementia. Therefore, there is a premium on trying to make an early diagnosis and detect symptoms relatively early. What workup should a primary MD carry out before referring to a specialist? At present, we don't recommend that the primary MD carry out and conduct blood biomarker tests because we don't have enough evidence yet, but this could change in future as studies of this type of workflow are conducted. In order to screen for MCI or mild Alzheimer's, the place to start is by taking a history. Often there might be symptoms of mild memory loss. Most complex ADL are intact, but there may be some subtle changes, having to write things down more, take more care, need a little bit of assistance or prompting, and very often getting collateral history from someone who knows the patient well can be helpful. For cognitive testing, the kinds of cutoffs we would think about for anti-amyloid therapy would be the Montreal Cognitive Assessment, or MoCA, usually scoring above 18 out of 30. Mini-mental state exam scores for lecanemab, the requirement was scores greater than 21 out of 30. For donanemab in the clinical trial, the requirement was scores of greater than 20. We need to try to rule out other causes of dementia or treat co-pathology or co-occurring symptoms. For example, if there is major depression, try to treat that. People should be in general good health, not taking anticoagulants such as Coumadin or apixaban, and should be able to undergo safety MRIs. If a primary MD is ordering an MRI for diagnosis, we would like them to include GRE or SWI sequences. This is gradient echo or susceptibility weighted imaging, and this allows us to assess ARIA risk, and if possible, try to obtain a volumetric MRI analysis, all of which can help in the diagnostic workup and in helping to consider someone for Leqembi. We would like the primary physician to be able to have a discussion with a patient about what is a diagnosis of MCI or Alzheimer's, that there will need to be confirmation with some sort of biomarker test. It probably is best if the specialty memory clinic carries out this testing. Treatment will require intravenous infusions every 2 weeks. If somebody is dead against that kind of treatment, perhaps they shouldn't be referred. And the likely costs. Lecanemab costs $26,000 per year, donanemab slightly more. While these are covered by Medicare, there may be co-payments for drug up to 20%, co-payments for infusions, diagnostic tests, and potentially safety MRIs. What does the memory disorders clinic do when we see somebody who might be an appropriate candidate for treatment? We will screen the patient by looking through the workup to date. We will review the diagnosis of Alzheimer's disease and the inclusion and exclusion criteria for treatment, and discuss whether the patient and their family has an interest in Leqembi or Kisunla. We will go through the clinical trial data. We will obtain an Alzheimer biomarker, most commonly either CSF or amyloid PET testing, potentially a plasma biomarker as more data becomes available on their utility. We will obtain an MRI with GRE or SWI sequences to assess the presence of microbleeds, or which is going to determine ARIA risk. And then we are required to obtain ApoE genotyping to evaluate ARIA risk. Some centers are not offering anti-amyloid treatment to people who are E4 homozygotes. We are, with appropriate discussion and appropriate care. And then we will have a detailed discussion of the results, treatment, risks, and potential benefits with the patient and their family. If we have someone who we think is an appropriate candidate for lecanemab that one of our neurology team has seen in practice, we will submit details of this person for review by a committee. At least 2 other neurologists review the clinical ApoE and biomarker data for each patient proposed for treatment and have to agree that this is reasonable and likely to be safe. And then we have the patient and study partner or informant sign an informed consent that reviews what's going to happen during treatment, what are some of the potential risks, what are the symptoms of ARIA, and steps to be taken in the event of these symptoms. We are then ready to start treatment, but we need to implement plans for monitoring. So we will regularly ask patients to let us know about their general health and cognition. They can communicate by phone call or through the electronic medical record. In addition, we will have regular clinic visits through video or in person during the infusions. The infusion center manages infusion reactions. These were reported in the clinical trials in up to 26% of patients, but were most often mild. If a patient has symptoms that might be ARIA, they may need to go to an emergency room. We will conduct safety MRIs at weeks 8, 12, and 26. If we detect significant or there is symptomatic ARIA, we will either hold treatment until the ARIA improves, or we, in some instances, will need to discontinue treatment. And then all patients are notified that new anticoagulation or treatment with intravenous TPA carries a major risk of intracranial hemorrhage. There has been a fatality in someone in the lecanemab clinical trial who received intravenous TPA. Therefore, if these sorts of treatments are necessary, lecanemab should be stopped, and we give patients education and also a wallet card that lists the antibody, mentions ARIA, and mentions this risk of anticoagulation. When treatment is initiated, we enroll patients in Medicare and in a registry. We organize the first infusion visit, and there is 2-hour post-infusion monitoring. The post-infusion monitoring gets shorter with successive visits. and we give the patient and family contact information and the wallet card. We might stop therapy in certain situations. One situation might be that we don't believe the immunotherapy is benefiting the patient. This could include progression of disease to at least moderate dementia. In the event of patient non-compliance, we might stop treatment. If there are adverse events in particular area, we may stop treatment after amyloid is cleared. For donanemab, this was done in their clinical trial because the antibody no longer has a meaningful target once amyloid has been removed. For lecanemab, it is not clear what the best option is because this antibody also targets a form of soluble amyloid in addition to the amyloid in plaques, and more research and studies will be needed. So how are we going to obtain real-world evidence beyond the clinical trials for how well anti-amyloid antibodies work? And as a condition of paying for treatment with anti-amyloid antibodies, CMS requires that every patient who is treated with an anti-amyloid antibody needs to be entered into a registry. There are several registries that have been established. CMS hosts one of these. Another was set up by the Alzheimer's Association and is called ALZpath. And then several states and some medical systems have implemented their own registries. The registries will allow us to obtain large-scale data collection, and this data can be mined for various outcomes and also to examine the costs of treatment and who ends up receiving treatment. The CMS registry, which is one of the simpler ones, includes all of the inclusion criteria for which a patient underwent evaluation before treatment. So for example, their age, sex, some other information about them, the kind of amyloid testing that was done, whether there was a mini-mental or a MoCA or a similar test, whether the CDR was done, and some evidence about their baseline MRI and whether they are on anticoagulants. The CMS registry also requires a scale called the Functional Assessment Questionnaire, or FAQ. The FAQ is an inquiry of an informant about how the patient is performing in various daily activities. The registry will give us lots of different information. In particular, it will tell us who is prescribed anti-amyloid antibodies. In the clinical trials that were conducted, it was largely Caucasians. In the donanemab study and the lecanemab study, moderate effort was made to try to enroll underrepresented minority participants, but nevertheless, there is relatively little information about whether they benefit to a similar degree, whether they have a different side effect profile, or whether there is anything different about their course following treatment. So the registry will give us a better idea of who receives treatment. How much attention do we need to pay to safety, and how easily can safety be monitored? In clinical trial settings, safety has very rigorous standards. There are, for example, central reads of MRIs and requirements for physicians to sign on and communicate with patients and so forth. What will happen in the real world? The registries will allow us to find out. And how well do the antibodies work in terms of providing slowing of progression? This will give us some idea of efficacy beyond the participants in the clinical trials in broader populations, more relevant to what we would think about as real-world practices. So there are some questions that came out of clinical trials. The clinical trial of Leqembi and of Kisunla, this is lecanemab or donanemab before they were given their marketed names, conducted a number of sub-analyses of different groups of people. So one question is, how well do these antibodies work among underrepresented minority patients? How well is ARIA managed in clinical practice? Are there sex differences in outcomes? In the lecanemab study, there was a hint that women do not do as well as men after treatment, but again, the study was not powered to directly answer this question. Do people who are ApoE, E4, E4 homozygotes have worse clinical outcomes and perhaps worse safety outcomes? There's a hint about the safety from both clinical trials. Certainly there are higher ARIA rates, although the ARIA was generally manageable. In terms of clinical benefit, the lecanemab study suggested that people who are E4 homozygotes do not show much benefit relative to people who received placebo. The numbers were relatively small, and we need more information about this very important question. How early should one start treatment for the best outcome? In the donanemab trial, they looked at tau PET burden, which required doing a tau PET scan. This is something that is not yet implemented or required in practice. It would be burdensome and expensive to do so. So one way of looking at how early we start treatment could be looking at the baseline mini mental state exam score or MoCA score to get an idea about how somebody does in response to treatment. And then do comorbid conditions such as vascular cognitive impairment or other general health problems, high blood pressure, diabetes, concomitant medications influence the outcomes. And one of the best ways to study this at scale will be through registries. So registries and treatment with these anti-amyloid antibodies have begun. Information has been collected for almost a year. And as time goes by, there will be enough information in these registries to be able to address a number of these important questions. For now, I hope that I've provided a background about the rationale for treatment, about how we would think of approaching who to treat, how to do the workup, what to discuss, what the mechanisms and the day-to-day components of treatment will involve, and how to monitor safety during treatment. Thank you.